If you are like me, you are terrified of the possibility that one day you might not be able to care for yourself due to some disease affecting your brain. And the drive to preserve our agency in this world is even more subtle than that. Thus, most of us would rather have a small myocardial infarction than lose 10 points in our IQ. It's for these reasons that recent observations with this new class of drugs, the GLP-1 receptor agonists, have elicited such excitement and is being pursued by researchers and indeed companies, some of which I've worked with over the years and I've collaborated with to help improve the lives of people with diabetes and are shown on this slide. So I'm going to address this question of neuroprotection with GLP-1 receptor agonists according to the outline that you see on this screen and that you'll see on several occasions during my presentation so you can keep track of where I am. So the first bullet really speaks to the title. Is the question in the title was to act. So what sort of evidence is required to act? And I'm coming from this from a clinical perspective as a clinician and a clinical researcher. And if we're talking about changing care and changing the way that we provide care, the bar of evidence is very high, and we need either well-done, large, randomized controlled trials or epidemiologic studies with effect sizes of 5 and 6 and 7 in order to start changing the way that we manage people and the way we deal with our patients to elicit neuroprotection. What do we mean by neuroprotection? So, for the purposes of this presentation, I think the clinical outcomes perspective of neuroprotection applies to either the central or the peripheral nervous system, and we're talking about humans only here. And from a central perspective, it's motor, sensory, cognitive, or affective function in either related to either cerebrovascular, neurodegenerative, and/or psychiatric disease. One could also talk about peripheral neuroprotection, but that is not the topic of my presentation today. And we can say that neuroprotection is there if over some period of time we're having a reduction in some stochastic outcome related to the brain, such as stroke or a disease diagnosis or dementia, or there's an objective improvement in function in people with dysfunction, or a reduced occurrence of dysfunction in people with or without dysfunction to start. So, GLP-1 receptor agonists. We know that these have been available to treat people with diabetes for the last 5 or 6 years or so, even actually longer than that. And more recently to reduce weight in people without diabetes. But the outcome trials that have been done are all in people with diabetes. So what do the outcome trials of these glucagon-like peptide-1 receptor agonists tell us overall, and about the effects of these drugs overall and in the brain? And we know that in people with diabetes, these drugs they work by slowing gastric emptying. They have direct effects on the brain to reduce appetite and other effects for sure. And they affect the pancreas by affecting pancreatic insulin release, facilitating insulin release in response to glucose stimulation. So here are the 8 outcome trials that have been done in people with diabetes, and they've all been designed in the same way. And the design of these trials, of all 8 of them, are shown on the slide here. So they all recruited people with type 2 diabetes, had to be older than age 50, and they had to be at risk for cardiovascular events, either because they'd had a prior event or because they had risk factors. They were randomly assigned to either the addition of a GLP-1 receptor agonist versus a placebo, which was identically appearing, followed for between 1 and 7 years, depending on the study, until the pre-specified number of outcomes had accrued, and the primary outcome for all of these included major adverse cardiovascular events, a heart attack, stroke, or cardiovascular death. They were all adjudicated. They had an independent data monitoring committee. And in all of them, the therapy of cardiovascular risk factors was at the discretion of the investigator, and that includes glucose levels, was at the discretion of the investigator, and A1C levels were open to people, as was blood pressure, etc. So they could manage them any way they wanted to, except they could not use a GLP-1 receptor agonist. So here's the 8 trials. As I said, the primary outcome was MACE in all of them, except for the first one, the ELIXA trial, where it also included unstable angina. You can see that they included between 3,000 and 15,000 people, and they ran between and they included between 30% in one study and up to 100% with prior CVD. So the lowest number of people with prior cardiovascular events was a rewind trial. They were all injectable except for the Pioneer 6, which used an oral version of Semaglutide. And the mean age was about 60 for all of them. The duration of diabetes was, I'll get to that in a second. Women were included between 30 and 46% of the time. The most was in the rewind trial at 46%. Diabetes duration was 10.5 years, between 10 and 9 to 14 years on average, about 10. Follow-up was 5.4 years in one study and 1 year in the other study, and with a range between the two of them. And the baseline A1C ranged from about 7.3% to 8.9%, and insulin use and up to 60%. What did these trials show in aggregate? So here's the meta-analysis that we just published a couple of weeks ago in the Lancet Diabetes, and you see in the middle column the hazard for these various outcomes, and altogether 31,000 people on GLP-1 receptor agonists and about 30,000 on placebo. So you see for the MACE outcome, the hazard was 0.86, so 14% reduction in MACE, a 13% reduction in cardiovascular death, a 10% reduction in fatal or non-fatal MI, a 17% reduction in stroke, and then if you look down the list, there's also reductions in heart failure that were modest and all-cause death. But the most important thing to note on this meta-analysis is that the effect size for stroke exceeds the effect size for all of the other outcomes. And that is not just in the meta-analysis, that is consistent across all of the GLP-1 receptor outcome trials. So it raises the possibility that this class of drugs is somehow, yeah, it's cardioprotective, but it's somehow brain-friendly, and there's some extra thing going on in the brain. As I showed you at the beginning, that meta-analysis included all the trials. The ELIXA trial was one trial which was different than the others in that it had acute coronary syndrome as an inclusion criteria, whereas the other ones were chronic cardiovascular disease. If you exclude the ELIXA, you see an even bigger effect on fatal or non-fatal stroke of about 19%. The message from this slide is that the cardiovascular outcomes trials of this class of drugs together suggest that drugs are somehow brain-friendly, having a biggest effect on the brain and at least on stroke. So I'm going to spend some time talking about the rewind trial, which is one of the trials I was able to lead. And this is one of those 8 trials. And as I showed you already, it was 10,000 people, prior CVD 31%, and followed for 5.4 years for a median follow-up period of 5.4 years. And the drug tested was Dulaglutide versus placebo as an injection, a once-weekly injection of a GLP-1 receptor agonist. And in this trial, we showed, like the other ones, that Dulaglutide reduced the MACE composite outcome. And there was also in the rewind trial a suggestion of a bigger effect on stroke versus the other outcomes. And here is the overall effect in the rewind trial. And here's the effect on the components of the MACE outcome. And you can see that the stroke curves diverge more than the other ones. When you see this in one trial, it means nothing. When you see it in all the trials of the class of drug, it starts to mean something. And then if we look at all stroke, there was a 24% reduction in this particular trial. And the components of all stroke includes disabling stroke and non-fatal stroke, consistent effects, very few fatal strokes. And if you look at what the type of stroke that was affected, it was ischemic stroke. And there were very few hemorrhagic strokes, but there was no signal for hemorrhagic stroke. And that's the summary of the effect of Dulaglutide on strokes in the rewind trial. And that's, I'm showing the rewind data because in that was the one trial where stroke was looked at a lot more refined way than the other trials. We also did a mediation analysis for stroke to try to determine or to try to understand, did any of the effects of dulaglutide mediate the effect on stroke? And this is exploratory. It does not prove causality in any shape or form. But in many of these trials, in all these trials, and in the REWIND trial as well, the drug dulaglutide reduces hemoglobin A1C, weight, and blood pressure. And so the hypothesis is the effect on these three things, which are all risk factors for stroke, A1C, systolic blood pressure, and weight, does the effect of dulaglutide on those indices somehow responsible for the effect on stroke? And when you do a mediation analysis, what you're doing, it's a statistical exercise, and it just supports or doesn't support a hypothesis. You look at the overall effect on stroke, which is 0.76, and then you say, and that's at the very top of that forest plot, there's the overall effect on stroke. And then you ask the question, what happens to that overall effect after you statistically account for the effect of the drug on A1C? And you can see that the 0.76 for stroke goes to 0.88. Or 0.85, depending on how you account for the effect on A1C. So there's some evidence that the effect on A1C is maybe statistically responsible for some of the effect on stroke. Same with systolic blood pressure. The 0.76 goes to 0.79 or 0.78, and weight, it doesn't affect the hazard ratio at all. So when you look at this, this tells you that, well, you know, about 40 to 50% of the effect on stroke can be statistically explained by the effect on A1C, and about 14% or a little bit less for the effect can be explained by the effect on systolic blood pressure. It doesn't mean that that's what's causing the benefit, but it supports a hypothesis that that might be causing it. And that's as far as I'm going to go about explaining it. Now, because I'm very interested, and most of us, we're all very interested in cognitive outcomes, and because it makes sense that a drug that's going to affect cardiovascular events should also affect one of the consequences of cardiovascular events, which is vascular disease in the brain and stroke and perhaps cognition. Way back when we were designing this trial, we said, let's include cognitive measures in this trial at the time, not because we suspected that it would benefit cognitive things, but let's measure it in case there's an effect. Now, is it easy to measure cognition in large trials? Any of you who have tried it know that it is not easy. In fact, it is frustrating, and the vast majority of large cardiovascular outcomes trials have not measured it, and when they've measured it, they've not shown an effect, maybe because of the way they've defined cognitive effects in the trial. So there is no magic sauce to doing this, so we tried something different when we did this analysis. So the meta-analysis of the trials suggests that there's a beneficial effect on stroke more than the other components of MACE outcome. And animal studies now, since we started that trial, have suggested a neuroprotective effect of GLP-1 receptor agonists. And so we had these two cognitive measures, so we explored the effect of dulaglutide on the cognitive measures that were measured at baseline and on 3 other occasions during follow-up in the trial. And the two tests that we decided to put in when we designed the trial in 2011 were the Montreal Cognitive Assessment Test and the Digit Symbol Substitution Test. The MOCA test was made famous by Donald Trump, who bragged that he got perfect on this test, which is not a difficult test to get perfect on if you're cognitively intact. Is a test, 1 page, 30 items. You test 7 cognitive domains, takes 10 minutes to do, and we validated the forms at the Population Health Research Institute when we were assessing it. And the digit symbol substitution test makes you put symbols into boxes which are numbered, and you want to see how many you can get correct in 2 minutes. And so those were both done locally at the sites all around the world in 26 different countries in all the sites. And these are all subjective tests affected by conditions under which they are taken. And we did not have trained administrators for these cognitive tests. We decided beforehand that we were going to standardize each person's test to what the mean was in their country by taking their score at any time point, divided by the country's mean score at baseline, divided by the country's standard deviation. And therefore, each person's score at any time point was a number of standard deviations away from their baseline mean of their country. And we country standardized them to reduce variation, because it's hard. And no one has done this before, and we thought, well, let's try something different, because other times when we've looked at cognitive tests and trials, we weren't able to detect an effect. So we wanted to remove as much noise as we could by country standardizing them, and and that's also culture standardizing them at the same time. So here's the example of one person's country standardized cognitive test. At baseline, it was 0 because it was standardized to the country. And then let's say at baseline, the whole country's was 0. That person's was 0.5. Another person's was 1 or minus 0.5, etc. They would have developed the predefined definition of cognitive impairment was if at any time point after randomization, their score was 1.5 standard deviations or lower below 0, because 0 was what their country standardized mean was. So that's what we predefined. And if Dulaglutide had no effect on cognitive impairment, similar numbers at each point would have gotten to a score less than or equal to minus 1.5. We restricted the analyses to those who did both tests. We did it, and these were the baseline characteristics, which I won't go through, other than mean age 66, diabetes duration 10 years. And the mean MoCA scores and DSST scores, if you're interested, are shown on the slide here. 24, 25 for the MoCA, and DSST was 38, lower than it is under ideal conditions in normal people at baseline. And the standardized score of about 0 is shown there as well. So what were the results that we found? Before I show you that, I'm going to show you evidence that this had a face validity. So we looked at risk factors for cognitive decline, and we tested whether any of the classic risk factors for cognitive decline in an epidemiologic analysis predicted that there would be cognitive decline, and they were. For instance, older, greater than 70, is a risk factor for cognitive impairment, and we found that people over than 70 were 25% more likely to develop cognitive impairment according to our definition than those younger than 70. Same with female sex, less education, prior cardiovascular event was not one, but prior stroke or TIA. So this analysis just showed that that a lower score at baseline, other risk factors for cardiovascular events, a high A1C, were all predictors of substantive cognitive impairment using the definition that we applied. So when we looked at that definition of the GLP-1 receptor agonist versus placebo, the top line there, substantive cognitive impairment was reduced by 14%, and that persisted after adjusting for age and ethnicity and education, and even after adjusting for strokes and death, etc. So we think this is a robust effect, and therefore in the REWIND trial, which is the only GLP-1 receptor agonist outcomes trial to date that has measured cognitive tests, we found that Dulaglutide reduced stroke, and Dulaglutide reduced new cognitive impairment. The cognitive tests, notably, were not designed for multi-center trials, and they add lots of noise, which is why we standardized them in the way that we did by doing the things that I've already described. What about other GLP-1 receptor agonists? Well, there have been a few other analyses done, but none of them in a large trial such as this. So recently, there was an abstract, not yet published, which was a pooled analysis of data from the LEADER trial with Liraglutide, SUSTAIN 6 trial with Semaglutide, and Pioneer 6 trial with oral Semaglutide. Total of 15,800 people with a median follow-up of 3.6 years. And the data, they extracted adverse events of dementia from the follow-up. And the pooled data were analyzed for dementia-related adverse events, and these occurred in small numbers, 15 GLP-1 receptor agonist people out of the 15,800 and 32 placebo patients. So it was less in the GLP-1 receptor agonist patients, and the curve share, the event curve is very dramatic. I'm going to tell you right now, do not believe a hazard ratio of 0.47 because when you do small numbers in any large, like this, there's lots of noise, and look at the confidence intervals as much as 0.25 to 0.86. But I think the message here is that it's consistent, and it supports a beneficial effect, a salutary effect of GLP-1 receptor agonists on more advanced cognitive dysfunction as measured by dementia as an adverse event. There was a small study online of Liraglutide and a cognitive battery. It was not a randomized trial, but it was two groups, sort of pseudo-randomized. Only small numbers, 47 people, but they did an extensive battery of tests, and they showed that there was, and they looked at a change in cognitive function on this battery from 0 to 12 weeks, and they found that 3 of the 9 tests improved Liraglutide, the other 6 didn't, and they used NIR spectroscopy and showed that Liraglutide activated the prefrontal cortex and orbital frontal cortex. I'm not sure what that means, but it's good. So that's just supportive as well. Other supportive studies, there was a sub-study of weight loss with Liraglutide, which showed that those who lost more weight seemed to improve in the Liraglutide group, had better preservation of their digits Z-score and their memory Z-score. So that's small numbers, but interesting. And there was an epidemiologic study suggesting less dementia with GLP-1 receptor agonists and other drugs based on adverse event reporting on the FAERS database in the FDA, and a case control analysis using the Danish registries. But again, these are large epidemiologic studies, and obviously you need to do the trial. There's intriguingly some evidence on Parkinson's disease, and there was actually a Cochrane review of the relationship between GLP-1 receptor agonists and Parkinson's disease, which only identified 2 small trials in the Cochrane review, exenatide versus placebo for 48 weeks and 62 patients, and another single-blind trial, 45 patients. And in both of them, there was an improved motor impairment with the exenatide group, supporting the hypothesis that there's some potential for the brain. And now another thing that affects the brain, Parkinson's disease. What about psychiatric illness? Well, this is another, we tend to think of the brain as cognition and motor and sensory, but psychiatric illness is another disease that affects the brain. And so brain health includes psychiatric diseases, and there maybe is a place. So there's been some exploration of GLP-1 receptor agonists in depression. There was a systematic review in 2010 in which a few RCTs were identified that were where the one blinded one was positive, the one that was open was neutral, and 6 uncontrolled studies were generally positive. So there might be a story there that needs development. There's been small studies and lots of narrative reviews discussing the potential for a GLP-1 receptor agonist in psychiatric disease, but we really don't know anything more than that. And so it's another question mark, which is what researchers do. And to their credit, Novo Nordisk has now started 2 trials in early Alzheimer's disease called the EVOKE trial and the EVOKE Plus trial. They are both double-blind trials, randomized controlled trials in people without diabetes or with diabetes. I don't think diabetes is excluded or included preferentially. It's either with or without diabetes. They have to be age 55 to 85, and they have to have mild cognitive impairment as well as a MMSE score which is greater than or equal to 22, so not be too cognitively impaired. They have to have a PET scan or a CSF sample that shows amyloid. So this is a very Alzheimer-specific trial, both of them, and that would be a criticism I have about them. And they had to have a clinical dementia rating score greater than or equal to 0.5 or a global score greater than or equal to 1, and a repeatable battery for assessment of neuropsych status score less than or equal to 85. And the first trial excluded people with small vessel disease, 1,800 people randomized to oral semaglutide versus placebo, and it's just started recruiting now. And the outcome is a clinical dementia rating score at change from baseline to 104 months. The other trial they're doing is identical, except it doesn't exclude small vessel disease, and the same number of people, etc. So, finally, can we explain the observed effects so far of GLP-1 receptor agonists on brain outcomes? So, I'm going to answer this philosophically. As scientists, we are doing empirical work. We are making observations. So observations are what we do best. Explanations are something that varies all the time. In fact, what I've said many times is observations are robust. If you keep doing an observation and you keep doing different variations on it and you see the same thing, you have confidence in that observation. So observations are robust. However, explanations are evanescent. And the explanation for what we see today is going to be very different than the explanation for what we observe 20 years from now. And the example I always use is if you dropped a stone from a tower that's 1,000 feet up, 500 years ago it would hit the ground the exact same period of time after you drop it as it would today, but the theory of gravity has changed 10 times in the last 500 years. So, and you know, when you look in the literature, what explains the effect of GLP-1 receptor agonists on the brain, you see stuff like this. I mean, to me, it's just throwing a lot of words on a page and saying, well, this, that, and there's things that are not on that page that could be just as important, such as small vessel disease and other things. So GLP-1 receptor agonists are given, they do something to some process that we either imagine or think is there, and then that affects cognition, memory, and other things. But I'm very cynical about pat explanations for things, and I like to keep an open mind because I know that they're going to change. Is the evidence that I've discussed so far sufficient to act? Well, I think the answer is no, clearly. That's why these trials need to be done. You should not be acting on any of this. It's an interesting and provocative and very encouraging set of evidence and hypotheses. So in summary, large outcomes trials in people with type 2 diabetes consistently show that GLP-1 receptor agonists reduce cardiovascular and renal outcomes, that these drugs have a greater salutary effect on stroke than other cardiovascular outcomes. The Rewind trials showed the stroke benefit was for ischemic stroke and reduced an index of cognitive impairment based on prospectively measured tests. A pooled analysis of 3 other GLP-1 receptor agonist trials suggests reduced dementia with these drugs. Animal studies and small human studies are consistent with the neuroprotective effects on cognition, memory, and potentially mood. And ongoing trials are assessing prospectively GLP-1 receptor agonist cognitive effects, and clearly they hold promise, but the answer is not there. So just to leave you with a final word, research is a never-ending journey, and sometimes while heading towards one answer, like what's the effect of this drug on cardiovascular events, we stumble upon new paths that lead to entirely new questions. Thank you for your attention, and I'm happy to entertain questions.